Thank you very much. Can everybody hear me okay? Good. It's an absolute pleasure to be here. I got here this morning and got to spend the day with both Bill and some of the student body. And I have to say this is still my favorite academic institution, despite all the other places that I've been. It is so encouraging to see how engaged and how sharp the students are that Gordon is attracting these days. And it makes me very proud to be from this institution, so thank you. My talk has two major purposes today. The first part of the talk, I'm going to focus on some of the history of cancer, how we have learned about cancer over time, and some of the more recent developments in cancer treatment and cancer research. And then the second part of my talk is going to focus a little bit more on my personal experience, specifically on the more spiritual side of learning how to treat cancer and how my own experience with my father's illness impacted that, and how the importance of my faith played a role in it as well. The first thing I'd like to do is just talk a little bit about what cancer is, because it is a concept that looms extremely large in our culture. It's a word that everybody dreads to hear, especially in an exam room or in a hospital room. And I think there's an enormous amount of mythology around the disease, and it's important to try to separate truth from fact. It's a disease that inspires fundraisers and cancer walks. It invokes ideas like battles and wars and valiant struggles. But I think in some ways we tend to give cancer a lot of power that it doesn't necessarily deserve. Cancer, at its most fundamental level, is a cellular disease. If you consider the body like a building, cells are the bricks that the building is made of. They're one of the lowest reductions of how complex a body can be. These are incidentally a cell line called HeLa cells. If anybody saw the book, The Immortal Life of Henrietta Lacks a few years ago, these are the cells that have been used in research for many, many decades. Life begins as one cell. We get half of our genetic material from our father and half of our genetic material from our mother. And from that point, life begins. The consolidation of that genetic material is what starts a human life. And the first job of a cell is to become two cells. One cell becomes two cells becomes four cells becomes 8 cells. And this process of division builds and grows and becomes more complex. These cells change shape, change form, and we end up with complex structures like organs, and eventually end up with trillions of cells. Cancer, at its most fundamental level, is a disruption of this process of cellular division and regulation of growth. Cancer develops when one population of cells in whichever organ outstrips the ability of the body to regulate that cellular proliferation. So when a cell develops the ability to divide beyond what it was intended to divide, a tumor grows. Cancer becomes an illness when that growth becomes disruptive to the organ that it starts in, or becomes invasive in surrounding organs. And this is why cancer can be such a destructive process in the body. Cancer has been in our awareness for a surprisingly long period of time. We believe that some of the first references of cancer are from ancient Egypt. This is a papyrus called the Edwin Smith Papyrus, which is believed to be about 600 years old, but references back to a time period of about 2500 BC. It refers to a cohort of women with chest tumors, and we believe it's the first mention of cancer in recorded history. The papyrus also states that the physicians at the time did not believe that there was a cure for this disease. The term cancer derives from Hippocrates, who first referred to cancer with the word karkinos, which is the Greek word for crab. He believed that tumors had the appearance of a crab reaching out into the surrounding tissue with its claws. And this is the term that we've referred to cancer with since that time. The term cancer itself was brought into Latin by a physician named Celsus. Cancer is a huge priority at the NIH right now. The operating budget of the NIH is about $31 billion every year, and between 5 and 6 billion of it is devoted to cancer each year. Just demonstrating how important this disease is to us, both culturally and how important it is for us to devote resources to develop treatments and cures. We will find a cure for cancer. It is coming. It is one of the most challenging medical struggles that we face, but I believe that that is simply because we are in the middle of the story and not at the end of it yet. One of the most common questions I get when people find out what I do for a living is, with all the money that we've devoted, why haven't we found a cure yet? And I personally believe that there's no simple answer to that question. The best way to think of it, in my opinion, is to compare it to how diseases have been treated, diseases caused by infections have been treated over the course of history. Even a very, very short period of time ago, infections held the same place in culture that cancer holds in our culture now. And this is just going back a few centuries. Infections were referred to with terms like consumption and bloody flux and the Black Plague. The Black Plague, we now know, is caused by a bacteria called Yersinia pestis and is treatable with oral antibiotics, if that gives you an illustration of how things change over time. The story of how we treat infections begins with a physician in Vienna named Ignaz Semmelweis. Ignaz Semmelweis was essentially the equivalent of a chief resident at the hospital he was in. And there were 2 obstetrics clinics set up in his hospital. One clinic was run by medical students, and one clinic was run by midwives. And he observed that the mortality rate among mothers in the clinic run by medical students had a significantly higher mortality than the clinic run by midwives, and became professionally obsessed with finding out why this was. And after attempting to isolate every variable he could, the only difference was who was running the clinic. And so he instituted a policy because he observed that medical students were going from the anatomy lab, where they were working with cadavers, to the delivery room, and midwives did not have that practice. So he speculated that there was some reason, something that they were transmitting to the delivery room that was causing this increase in mortality. This was far before germ theory was ever proposed by Pasteur. Nobody had the concept that there was some invisible material that could be causing this issue. His simple intervention is one that we still use in the hospital today, and it was just wash your hands. There's something there that we need to clean. And when he instituted that policy, the mortality rates normalized completely, became equivalent. This is the type of discovery that we see as a major milestone in research history. It wasn't until about 80 years later that we started to develop the ability to treat infections. Alexander Fleming was a British scientist who returned home from vacation and noticed a number of petri dishes with Staphylococcus growing in them had also developed some moldy growth on top of that. And he observed that around the edges of the moldy growth, there were no bacterial cultures growing. And he speculated that possibly the mold were producing something that would inhibit the growth of the bacteria. And so over the next 14 years, attempted to purify the material from this mold, and ultimately saved the first patient from sepsis with penicillin 14 years later. And this is a list of the antibiotics that we have available today to show you that even in a relatively short period of time, medical progress does move, even if it doesn't seem like it at the moment. The analogy to cancer I believe, starts with a physician named Sidney Farber, who was a pathologist at Children's Hospital in the 1940s. He observed that children with cancer often had a very short life expectancy, and there were very few interventions that the physicians had available to try to extend their life or to treat their symptoms. And he wanted to find a way to start figuring out how we could fix this problem. He chose acute leukemia as the target of his research and selected a group of patients that he was going to attempt to treat. A number of his colleagues were treating blood disorders with a vitamin B called folic acid at the time, and so he speculated that perhaps this would have some benefit in acute leukemia. The brilliance of his choice of acute leukemia is that this was the pre-radiology era, and so there was no way to measure the effect of a treatment on solid tumors at the time, but they could draw blood from these children and count the number of cells that were in their bloodstream. And he speculated that this would give him the ability to monitor a patient's response to treatment. Unfortunately, folic acid did not have the effect that he was hoping. In fact, he found that it accelerated the patient's disease, and they actually died sooner than they would have expected. But this gave him the ability to speculate with a biochemist colleague of his that if they could develop a medication that acted as an antifolate, that this might have some benefit. The drug that he developed was called aminopterin, and he found that when he administered aminopterin to a group of pediatric leukemia patients, that their cell counts came almost to normal, and their lives were much longer than we would expect. And this was the birth of chemotherapy. One of the major challenges that we have had since that time is that's what we call cytotoxic chemotherapy. Is a class of medications with an enormous toxicity burden. The side effects of these drugs is quite significant, and that often limits the doses that we can use in cancer treatment to effectively treat tumors. The problem is these drugs act to inhibit the proliferation of DNA in the cells. And while attacking the cancerous cells, the healthy cells are also innocent bystanders of administration of the drug. And this has been one of the major limiting factors in cancer treatment since we started using chemotherapy. So I wanted to highlight a few of the more sophisticated advances that we've come across over the last few decades. The first one begins with a disease called chronic myelogenous leukemia, which is slightly different from the leukemias that Dr. Farber were treating. In the early 90s, we identified that chronic myelogenous leukemia is driven by one chromosomal change, where the arm of one chromosome, chromosomes are the packets of DNA that exist in our cells, breaks off and swaps places with the arm of another chromosome. And what this does is it makes a new protein that doesn't exist in the genome naturally. This protein causes cells to divide completely outside the regulation of normal cellular division. And some very enterprising scientists at the drug company that has now become Novartis recognized that if they could model that protein and design a drug that might interfere with the function of that protein, then we might have a new class of medications that could treat this cancer. So by using the technology that they had at the time, they were able to identify the shape of this protein, which you can see. Do I have a pointer here? So this is the natural form of the protein and the use of an energy molecule that drives unrestrained growth. And the scientists at Novartis developed this drug that fills this site and impairs the function of this one specific protein. Now, the beauty of this drug is that it generally doesn't have much of an effect on normal cells at all. And this was one of the first examples that we have of what we call rational drug design in oncology. The effect now is that I have patients who have been on these medications for decades, and their tumors are under complete control. One of the other great breakthroughs that we've had in oncology treatment is the class of drugs called monoclonal antibodies. And this is an extremely broad class of medications, of which we now have dozens of agents. Antibodies are the foot soldiers of the immune system, in a way. They exist in all of us right now, and their job is to identify things that our body would consider foreign and attack them. And the way we have harnessed the power of these antibodies is that we've actually developed the technology to design antibodies that target something specific. So we know that there are elements on the surface of cancerous cells that don't necessarily exist in the rest of the body. And we've been able to design antibodies specifically to attack those things. And then we've even taken it one step further, where we've learned to attach, for example, something like a chemotherapy drug to the non-functional end of an antibody and essentially deliver chemotherapy specific to a cancer cell where it doesn't attack the rest of the healthy cells. So these are another major quantum breakthrough in cancer research. Dr. John Harris is over in the back row here. He's one of my classmates both from Gordon and from medical school, and we actually worked on our PhD projects together, so I knew he would appreciate this. I actually didn't know he was coming, so thank you for coming. What in my opinion is one of the greatest breakthroughs that we have in cancer research has just happened within the last decade. And this is an entirely new class of drugs that we call immunotherapy. The concept behind it is that rather than trying to attack the cancerous cells with the medications that we administer, there's this theory that the reason everybody doesn't develop cancer is that our immune systems have the ability to fight cancers off that do develop. And for some reason, in patients who do end up developing clinically significant cancer, those cancers have learned a way to evade the immune system and its natural functions. The concept of immunotherapy is administering medications that essentially unmask the tumors from the immune system, give the immune system the ability to essentially wake up to the patterns of those tumors and let the immune system do its job in fighting off the cancerous cells rather than administering medications that are going to be toxic to the whole body. And over the last 10 years, we've actually had incredible success in most tumor types. In using these medications, we've found that even in the metastatic setting, patients have longer survival and significantly less toxicity than when we use cytotoxic chemotherapy. And these are just the advances that we've had in medical oncology, which is the field that I work in. We've also had incredible progress in surgical oncology, in radiation oncology. We have non-invasive techniques where tumors can be ablated by interventional radiologists without ever putting in an IV or using a scalpel. And we've also had major progress in endeavors in screening, such as with mammography and colonoscopy, and with lifestyle modifications such as anti-smoking campaigns, where the overall survival in some cancers has gotten significantly better, and the rates of developing some cancers has decreased significantly over the last few years. So I believe we are positioned to cure cancer, if not in our lifetime, then in the next one. The reason that we have not come up with a cure for cancer is because there will likely never be one cure for cancer. Cancer is dozens or hundreds of different diseases, and each one is treated differently and will require a different intervention. But I believe we will get there. The second part of my talk, I would like to reflect a little bit on my own personal experience through cancer training, and I will beg your forgiveness, but I'll need to read it a little bit more because otherwise I won't be able to get through it. The day may come when a cancer diagnosis is no scarier to us than a diagnosis of strep throat based on the medical progress we've made. But what do we do in the meantime? I can attest from my own experience in my family that news of a cancer diagnosis strikes fear like few other things. And I can also tell you that few things have challenged my faith and my perspective on God's character then my dad going through treatment for lung cancer and ultimately passing away a year after I graduated from Gordon. It's very hard for us to reconcile the idea of a loving God who wants the best for us and a life circumstance that's this painful and confusing. And this tension continues to tug at me. But I did learn a few things in the process. First, I learned that it is incredibly risky for us to speculate or claim to know God's intentions for our life based on our circumstances. A claim that a diagnosis of cancer or the impending death of a family member is, quote, part of God's plan, even when said with the best of intentions, can be very damaging to people in the midst of suffering. It is more comforting for others to just sit in the pain with people who are suffering rather than attempt easy platitudes. I also learned that painful and tragic circumstances can reveal to us our own powerlessness, and this is sometimes a good thing. Ultimately, faith in a God who wishes good for us at times can be the only solace that we can find in circumstances like this. And it took a long time, but ultimately I learned that peace can be found when I stop trying to understand why this had happened to us or why it happens to anybody. It's very often that patients who I talk to interpret a circumstance like this as a punishment from whichever God they worship. And faith in a God who is redeeming creation, rather than seeking revenge on it, can be very, very comforting. And finally, I learned that prayer is an essential practice, but unfulfilled requests do not mean that nobody's listening. I have met some of the most committed believers in the hospital, and despite a toxin-free life of service and selflessness, suffering and dying were still their outcome. The patients with the strongest faith simply don't take it personally. They recognize that the universe is immensely more complex than we can ever fathom, and to attempt to draw conclusions about ultimate reality from the limited set of data that our immediate circumstances provide will never generate an accurate picture of reality or of who God is. Finding the cure for cancer is incredibly important, and I believe it's a good use of our time. But I also believe there's a larger picture that we in the church have the perspective to appreciate. Cancer and every potentially terminal disease is scary because it changes a patient's and a family's life dramatically, sometimes irreversibly. Cancer causes pain and suffering, and many times a patient's death arrives sooner than it would have. But we in the church know that there's hope even in the midst of death, and that there may be redemption even amidst the incredible suffering that cancer might bring. Thank you.
Thank you, Dr. Bishop. Really appreciate that. Not only did you offer us a lecture that was historical and professional, but also profoundly personal. And so we appreciate your authenticity and deep care for this community and sharing that. So we do thank you. At this time, I would like to introduce you to the lecture respondent, who is also no stranger to the Gordon College community. Dr. Naveen Moody is a family medicine doctor in Danvers, Massachusetts. He is affiliated with multiple hospitals in the area, including Brigham and Women's Hospital and Mass General. Dr. Mahooti graduated from Gordon College in 1996, during which time he was part of the Gordon at Oxford program as a graduate student from 1996 to 1997. And he received his medical degree from the University of Connecticut School of Medicine in 2006. Additionally, Dr. Mahooti is the team physician here for Gordon College athletics, and that's fitting considering he played baseball for the college during his student days here at Gordon. In fact, I texted Dr. Mahooti earlier today and asked him, is there anything else you would like me to share during your bio introduction? And he said, yes, as a matter of fact. I'm going to read this to make sure I get this just right, because apparently this was really of great significance here. So, Dr. Mahooti says, yes, I still hold the all-time season record for lowest ERA at Gordon for starting pitcher, 0.81. It is in the Gordon baseball website, 21 years and going strong. So there you have it. Yeah, right. On a more serious note, Dr. Mahooti has a very thoughtful and Christ-centered desire for integrating his faith into his medical profession. And because of that desire of his to integrate faith into the medical profession, we thought he'd be an ideal respondent today. Finally, I will say it has been a delight to get to know Navid and his wife Lisa a little bit in the past year. Not only do I enjoy conversation with Navid, he also quite recently brought some pain relief to my knee in his clinic as a patient, so I appreciate that. I can tell you he knows what he's doing. I will say this in light of Dr. Mahooti's current injury. My general perspective on the hermeneutical framework for interpreting the Scripture says don't take Scriptures out of context, but I can't resist thinking physician, heal thyself. So in any case, please join me in welcoming back Dr. Naveen Moody.
I didn't tell him that. I promise I didn't. Here we go. So thank you so much. Is it showing up there? We good? I can't see. It's up? Thank you. Okay. Thank you so much for having me. I am married to a lovely woman who just snuck in here earlier today, and my wife Lisa is an Emmy Award-winning producer from ESPN. She's also written a book that's won some accolades, so I certainly married up. But my wife has taught me the power of story, and I've certainly sat through many lectures like this, incalculable number of lectures like this through medical school, and I've given a number of lectures like this, and I'm going to try something a little bit different today and make this more of a story as opposed to just facts. And so hopefully you'll learn a little bit more about me and some of my passions and things that I enjoy doing, and also maybe take away some thoughts, not to the, I don't think to the extent of Ken's, that was Dr. Bishop's, that was quite powerful, so thank you for that. But I was born in Iran, Tehran, Iran, 1974, and I was the youngest of 5. 1976 was a good year. These are my siblings and me. I'm the youngest. Guess which one's me? We came to the States in 76 as an immigrant family. 1979, bad. Not a good year with the Iranian hostage crisis. Many of you may have lived through that and known that. These signs of deport all Iranians, it's interesting how things kind of cyclical in our lives. Was not a great time in our family, a very difficult time in our family. People look at this and say, Iranian Christian, those two words don't go together. How did that happen? Well, the story with that began in 1947 when my mother, who was the oldest of 6, passed away. Her mother passed away from encephalitis, and my depressed grandfather, who was on a bed of suicide, fortunately he didn't take his life, sent my mother and 2 of her sisters to England to go to boarding school. My mother met Christ there. My grandfather knew that Christians were good people, and he sent my mother to the boarding school because he knew she'd be taken care of. So in a span of a few months, my mother lost her mother and effectively lost her father because she was sent away to the school. She didn't know the language very well, and she was in post-war England. Any stiff upper lip Brits here? Not the warmest place to be in 1947. So she ended up going to medical school. She became a physician herself. This is a picture of us together right outside where she went to medical school, Royal Free Hospital. As Dr. Bishop mentioned, most of us who are going to the fields we go into, and I think medicine is especially true of this, something in our childhood often shapes our experience, shapes who we are, and propels us to whatever field we go into. And in medicine, it's especially true. For me, I sustained a pretty significant fracture to my left leg. That's not me playing basketball, and that's not me in the cast, but Google's a wonderful tool. I couldn't find any pictures. I can't get around my house. What do you want me to do? So, but that's about the fracture I sustained. 16 years old, pretty devastating. I ended up coming to Gordon. No, these were not my professors at the time, but they're here now. Played baseball. That's not me again. And as Dr. Barker said, I studied medical ethics and theology at the Gordon at Oxford program as a graduate student. So a lot of the thinking about what Dr. Bishop talked about, much of my thinking about these topics began at Gordon, was nurtured during my time at Oxford, and ever since then I've been contemplating these deeper questions, as many of us do. Studied medicine at UConn, did a master's in public health at UConn as well, and ended up going back to UConn to do a fellowship in sports medicine. My public health degree was in a topic, medical care for the underserved, a faith-based approach in Hartford, where I wrote a thesis looking at ways to develop faith-based clinics. And we did one, we created one in Hartford. If anybody is suffering from insomnia, and you'll go online, you can find that article there, and it'll put you to sleep in a matter of minutes. This is my lovely wife and my 2 kids. This is just a snapshot thrown in there courtesy. This picture here is an important picture to me because it shows several generations of Gordon here. So my father on the left, who was celebrating his passing 10 years ago, is there with my mother, who's celebrating the birth of my second niece, with my sister, who was a graduate of Gordon, and she kind of trailblazed the way for my brother and I, who both came to Gordon as well. And in my sister's lap, with the blonde hair, is my niece, who's now a freshman at Gordon this year. I won't use any names so as not to embarrass her, but she's not here right now. She has choir practice. I'll give you a little hint there, but she's at Gordon now, so multiple generations. My practice, 10 minutes up the road in Danvers at the beautiful Mass General building. Very fortunate to be there. And as Dr. Barker said, I serve as team physician at the college. 6 years ago, when I completed my fellowship, 7 years ago, when I finished my fellowship and was looking for a job, I had a deep longing to return to the Gordon community. As Dr. Bishop says, this is the academic institution that I'm most fond of, the memories here, and fortunate to be able to return and bring my family and start a family here and be part of the Gordon community. So September 20th, 2017 was an ominous day for me. People see me on this little roller here. I was just playing basketball early in the morning before work, and that's kind of what happened to my leg. I knew it happened pretty much within 30 seconds of it happening. I felt somebody kick me in the back of my leg. I thought somebody kicked me and turned around and said, "Who kicked me?" And nobody answered. And I was in a state of kind of, what just happened here? And then I kind of said, wait a minute, if you look in the textbooks under Achilles ruptures, that's what it says. It feels like somebody kicked you in the leg. If you look at the statistics, which I wish I had looked more closely before I got on the court for the past couple months, the mechanisms of rupture, if you look at that middle slide, 32% of all Achilles ruptures playing basketball, and 47% occur in sports playing basketball. So, yes, this was me trying to dunk on somebody, and that's how it happened, actually, right there. But if you look at the average age of when these occur, the Achilles ruptures, it's 44. Guess how old I am? Anybody? Math? 43 and 9 months. So you 44-year-olds out there, Carter, I see you. Be careful getting on that court. Just coach. As I contemplating what is a sports doc like me doing, following up MD, PhD with the experience and the scientific background that Dr. Bishop has. I'm often taking care of people who are kind of in the fittest part of their lives to sustain an injury. He's taking care of people who are in their weakest, most vulnerable places in life, who are oftentimes weeks or months from death. But part of my practice is primary care as well. So about 25% of my patients are primary care, family medicine patients. And often I'll ask my patients, what gives your life purpose or meaning? It's kind of an open way for me to get to know them a little bit, get their worldview, and you never know what they're going to say. And I wish I could say that profound things come out when I ask that, but they often don't. And I don't know what that's a sign of, but I'll ask, and they will look at me sometimes perplexed, and they feel like this is an important question. I should probably give some kind of a profound answer. So usually, what do you think comes out first? What do people say? Family, exactly. All right, so you've been asked that question maybe? Yeah. So very often people say family, and rarely people say my faith. Very rarely, unless they know me from Gordon and they come and I kind of know, and they probably feel they're obligated to say that, and they say it. But it doesn't provoke the response that we think it should, which is interesting to me because coming to Gordon, this is the things we think about all the time. At least I think we do. So I thought of a thought experiment when I was looking at Dr. Bishop and what he's talking about and some of the insights. And I thought, if you were to ask a cancer cell, what is your purpose? What gives you meaning in life? How would that cancer cell respond? What would the cancer cell say? So you can think about that for a second, maybe. So as Dr. Bishop talked about, he gave the analogy of a cell, one cell like a brick in a building, making up the building. It's the building block. If you think of a cell as a city, and there are so many different moving parts to a city, but you can boil down one cell in the body to literally a city with all the enzymes and proteins and transport that is taking place within that city to make sure it runs smoothly. And as he was alluding to, cancer is where there's a disruption in that machinery leading to one cell going rogue, if you would, and dominating, taking over, and just multiplying, escaping its designed order and plan, and doing whatever it needs to do to multiply, spread, and conquer. It's quite remarkable when you look at this, and he could answer this better than I can, why cancer doesn't occur more often than it does. When you look at the fine-tuning within a cell and all the potential areas where something can go wrong, why doesn't cancer occur more often? Maybe you can answer that. And that's my question for you, actually, if we're doing questions. Why does it not happen as much as it does? Good. I get the first question. As I thought of this, I think cancer is like an extreme megalomaniac. A cancer cell is unwilling, or even worse, unable to recognize how its insatiable desire to grow, invade, and consume without boundary ultimately leads to its own demise, the often painful death of its host, right? So a cancer ends up killing itself out of its ambition to grow and take over. It's a very interesting, you can play with that theologically quite a bit. A cancer cell you could think of as on a self-indulgent suicide mission. Here's another thought experiment. When you think about cancer, life, death, faith, is a cancer cell successful in what it achieves? Well, it all depends on how you define success, I guess. Bob Dylan says, a man is a success, or a woman, if he gets up in the morning and gets to bed at night, and in between he does what he wants to do. Okay, pretty good, not bad. What about Abdul Kalam, former president of India? Well, he looks at it more from a fame standpoint, where he says success is when your signature becomes an autograph. Okay, interesting. What about popular speaker Tony Robbins? This one struck me. Success is doing what you want, when you want, where you want, with whom you want, and as much as you want. A little bit of ego built in there somewhere, I think. Well, if we think about Robbins's comments, are they correct? You know, in what universe is what he's saying true or correct? Well, as I thought about that, I think there's two. If one's worldview excludes the transcendent, or if one views oneself as transcendent, I think Robbins is onto something. But we know that we are not transcendent. We are created beings. There is other. It's not just us. There is a transcendent God who created us and whom we follow. What if we were to take the word cancer and replace it into Robbins's little paragraph in his little poem? Cancer does what it wants, when it wants, where it wants, with whom it wants, and as much as it wants. And this is a picture of a cancer cell as it's invading. It's just a nasty-looking cell. Now, as I thought of this, I see cancer as a metaphor for sin, actually. Sin blinds us from other, It focuses us on self, and it leads us to our own demise. Right? That's what sin is. So there's a real analogy there with cancer. Now, what is a physician's role in all of this? Right? I'm taking care of physical ailments mostly, and it's interesting. I invited a friend to come to this talk who's a local doc, and the doc wrote back and said, and I wish I could come, I have another appointment, I can't make it. Someone who was kind of on the fence, so I'm not quite sure of the faith background, but he said to me, medicine and faith, there's like a separation of church and state that's an unwritten rule. And this is this is a very interesting talk, but his perspective, how he was trained, how he's thinking is these are two, you can't mix these two. You can't mix church and faith, church and faith with medicine, which is very opposite from how I was trained and how I think and how I approach my patients. But what is a physician's role in this? So briefly, from my perspective, a couple questions for you folks. This may give us some insight into this. Do you know the faith and beliefs of your physician? Anybody here? Anyone have unless they're me, some of you are probably here, patients of mine actually, but anyone here kind of know what any idea what practice? Probably not. Yes. Okay, yes, you do. Okay, good. Okay, maybe good. Another question. Has your physician asked you about the importance of your faith in your life, about your religious background, your faith, your purpose, your meaning in life? Anybody? Can anybody? Yes? If you have a yes, just no. Yes. Okay, good. I'm not hearing many yeses. I heard one. So not typical. Okay, a few. Does your physician know about your faith practices or your beliefs? Have they taken any time to ask or inquire about that? I'd venture to say probably not. What does that tell us? Well, if we look at the literature on this, it's replete with studies and evidence suggesting we should be doing, as physicians, a better job asking our patients about their faith background. I have several things here. This is from American Family Physician, 2012 publication, but when you look at the importance of this issue, it's been researched. If you look at a physician's beliefs and how they've been documented, that's been studied. If you look at certain guidelines from the Joint Commission and others, it's encouraged and mandated actually for the Joint Commission to get a spiritual history on patients. If you look at patient desires, the majority of patients want their physician to ask them, inquire. They want to be able to talk a little bit about or something about their faith and what makes them tick. They want it to be patient-centered. This has all been studied. They want their needs addressed. There's issues of doctors who are not doing this, and studies have been done looking at barriers of why aren't physicians asking these questions. And that's been studied, and there's solutions that have been put forth for that. There's been training tools out there to help people ask these questions and to inquire about them. And the relevance of it has been well documented in terms of outcomes and how well people do when their doctors know about their faith background and that facet of their care. It's not just the physical body you're taking care of. It's a person, it's their spirit, it's their soul, it's all those things. Which patients should be inquire? Which patients should we ask these questions about or delve into that? Well, if somebody comes in and they sprain their knee, I'm not going to be asking them about their ultimate meaning in life. But if someone coming in and they're sick, or if I'm part of my annual visit or certain other components of care, that would be an appropriate time. Why? For many reasons. Mainly because if something does happen, I want to know how they cope. I want to know how they get through, how they make it through, and we can care for them better that way. So what ought a Christian or a physician do in these circumstances when all this literature is placed before us? Well, when I did my MPH thesis, I spent a lot of time looking at this type of interaction that physicians have with patients and how do we best inquire and help patients to talk about these issues that are often important to them. Probably more often than my screening question. I think I need to rework my screening question of meaning and purpose. That may be a little, not the greatest screening question. But there's little assessments that we can do. One is called the HOPE spiritual assessment, where HOPE stands for sources of hope, or hope, organized religion, personal spiritual practices, and effects on their medical well-being. So this is a mnemonic that doctors can use to ask patients questions, and you just go right through the line, and it incorporates a lot of the different components of a spiritual assessment. The second is the open invite. So you open the door, and then you invite somebody in. So how do you open the door? You ask, may I ask you, what's your faith background? It just opens the door. Some people will say, I don't have one. Okay, maybe not that time. You can revisit it later. Or you say, what I often will say is, well, did you grow up in a church? Did you grow up in a certain faith or religious background? And oftentimes that can open, yeah, I used to go to church, but I don't go anymore because of X, Y, and Z. And then you can start opening the door and asking a little bit more about that. And the third one, which is classically the one that I've trained most in and have used the most, is called the FICA, Spiritual History Tour. This is, you ask someone, do you have a faith or a belief, a system that you ascribe to? If they say yes, you say, is that important to you? And you go into the questions about importance. If they say yes, you go to community, or you're part of a faith community, a church, a temple, whatever it may be. If they say yes, then you go to, how can I address this? How can I help you in this area as part of your medical care? And often people are excited about it, and they're happy to share about it. I just want you to look at this picture for a moment. When I was at Gordon, the notion of servant leadership is the first time I'd ever heard that term, was embodied for me as I learned about Christ and about his love for us. And this painting has always been a real tug on my heartstrings. I have a book in my office called The Life of Christ in Art, and I leave it in one of my exam rooms, and patients often will pick it up and read it, and they say, I never expected to see a book like this. And I say, tell me more about that. What do you like about it? And then they say, oh, I like this picture. And then I'll open up to this picture, and I'll show Jesus washing Peter's feet. And I just love Peter's expression, looking down, ashamed, embarrassed. He's being served. He's being cared for by his leader. And you look at, I'm not sure who that is in the back left, covering his hands, thinking, oh my goodness, the Lord's going to do this for me, to me. How can I let this happen? But this picture to me is an embodiment of what medicine is, and daily what I try to be for my patients is try to be Jesus for my patients. That's a difficult thing to say because I fail at it much more often than I succeed at it. It's humbling. Medicine can be very frustrating. There can be a lot of pressures, getting through paperwork, getting through phone calls. Not everyone's easy to work with, or can be a real challenge. But I think of this picture, and I think of myself and what I learned here at Gordon. And your students who are here are very fortunate, incredibly fortunate, because what I just talked about here, I don't know anyone in my medical school who could articulate any of these ideas. And the foundation of these came through my education here. So I encourage you to study hard. If you're interested in the health sciences, there's a world out there of literature to explore and to train yourself to deal with these issues when you're dealing with MD PhDs in your university who look down on this kind of stuff, not our colleagues here, but they look down on these types of things. To be able to articulate, show them the literature, and just live by example can have a profound impact. So thank you for your time.